Dr. Sengottuvelu in the live case.
Good morning, Sushil. Can you hear us?
Yes, we can hear you. Please go ahead.
Yeah. So it's a real honor to do a live case to TCT India and in the front of esteemed panel. I think Sushil, Ramesh, Ajit, and Dr. A.B. Mehta, and then so many of them are there. So nice to do this case. We have a good team here. Dr. Muthu is my colleague, who will be my second operator. Sendil, Andrews, our technician, and we have anesthetist Dr. Ganapati. So let's now go to the case. Can you have show the slides, please? Yeah, show the first slide. Yeah. So this is a 64-year-old male. He's a diabetic, and he had CABG surgery in 2011 with Lima to 3 grafts: Lima to diagonal and a skip graft to obtuse marginal and Rima to LAD. Subsequently, he was found to have occlusion of the circumflex graft, OM graft. So he had a stenting to circumflex at 2017. And since the last 4 months, he was found to have symptoms, class 3 symptoms, exertional angina. And his CT showed a patent grafts, and the stent to circumflex from the left main was patent. So he was found to have severe aortic stenosis. And his STS score was 3.2. And ECG, was testing ECG, no conduction disturbances. And the next slide. So echo showed severe aortic stenosis with a mean gradient of 47 and mild MR with the normal LV function. And he was with the CT. He was assessed with the CT. And as you can see, show the previous one, please. So if you look at the CT, the perimeter derived diameter was 23.7, and the area derived diameter was 23.5. So if you look at the LVOT, it was still smaller. It was the perimeter derived 23.4, but the area derived was smaller, 21.5. The coronary heights were quite high. Coronaries were high, with 16.9 on the left and 22 on the right. So the sinuses were wide. And next, please. And you can see some calcium in the annulus. It's a bicuspid valve. It's a type 0 bicuspid. And you can see the LVOT, which is narrow. The calcium score was around 1000. There was moderate calcium. And if you see this run of at the level, you can see the calcium in the leaflets, some calcium in the annulus. Next, please. So his ascending aorta was not very dilated. So the angle was not very horizontal, quite favorable. And if you look at the iliofemorals, it was quite large, and both the left and the right. The right had both the bifurcations were low, so we took the right axis, and you can see the bifurcation quite low. So the right axis. Next, please. So to summarize, this is a 67-year-old man with a post-bypass surgery with the severe symptomatic aortic stenosis with the type 0 bicuspid valve, and with the moderate calcium. And if you look at the annulus, it was a little, compared to annulus, LVOT was smaller. The stents and the grafts were patent, and he had the good access for transfemoral access. So with this, yeah, Sushil, please go ahead.
No, I know before you tell us what you decided to do, maybe it'd be worth getting some comments from the panel, because I think we saw a nice type 0 to start. Each one is very different. So maybe going down the panel, we'll talk, and one critical consideration and what you would do, and go down the panel.
Yeah, I think the accesses are good. It's a bicuspid type 0. The coronaries are protected. I would not have to worry too much about that. There is calcium. I could use any of the valves, but it's 23.5. So you could use either of the 2 valves, the self-expanding or the balloon expandable. I wouldn't really worry about what here on this patient. I would predilate because it's a bicuspid with calcium. And I would just use a safari wire to implant this. I don't think we'll have too many issues.
But so evolute by perimeter, it would be a 29, but would people downsize to a 26?
Yeah, I would possibly, because the aorta is a bit narrow. Maybe you downsize it to 26.
Well, I just I just was an additional point, Sengottuvelu.
Yeah.
Do you
Yes.
routinely measure the membranous septum? Because if you are going to use a self-expanding valve, this may be a pertinent point.
Yes, perfect. I mean, we don't do routinely, we don't measure, but I think particularly when you use a self-expanding valve, I think it's a good idea to measure know the risk of conduction system disturbance. In this case, we are the ECG didn't show any pre-existing conduction system block, and we're not going to show we are not going to use a evolute valve, so we are not really concerned about conduction system in this case. But of course, it's a good idea to measure the membranous septum.
Saurabh, you do a lot of balloon expandable sapiens. Any concern with balloon expandable with this anatomy?
You know, in bicuspids in general, I'm always concerned. If you look at the data behind it, even though multiple registries show similar outcomes, but certainly just having done hundreds and thousands of these are experiences that bicuspids in general are a little less.
Yeah, that's fine.
So the one consideration would be what Sushil pointed out, that you'd probably be with a 23 balloon expandable valve here versus a 29 sapien. It's a young patient. So I think important to consider what their functional capacity is, how active they are, and how much residual gradient you would get. You know, these 23 balloon expandables are experiences that 30 days out, 3 months out, their gradients always tends to be higher than what you left them with.
How big was this patient?
He's a kind of a moderate build. His height is around 162 centimeters and weighs about 70 kgs.
Yeah,
it's a typical Indian, not too obese or no body surface area is not very big.
Yeah, I think it's Sengottuvelu is Anand here. I think the body surface area is medium, so balloon expandable, self-expandable, both will work out well. The patient person is will not be much. Between the self-expandables, I think what is important, especially next year in India, is you'll have 7 different self-expandable valves. And people need to understand these valves and also understand which of these valves are indicated for a tricuspid and which of these are indicated for a bicuspid. That's very important. This case you can do with any of the self-expanded valves, as we discussed already, evolute or accurate or whatever it is. But as such, the indicated valve is the important thing.
Yeah, agree. So I'll proceed. So looking at this, I think we all agree that this patient needs a TAVI, because post-CABG patient, in a 65-year-old post-CABG patient, definitely would consider TAVI as an option. It's simply a symptomatic AS. So even though it's an intermediate risk, clearly this patient doesn't have any features of iotopathy, and he's got annulus. So we decided that we should go with even though it's a type 0 bicuspid, we thought we'll go ahead with the TAVI. We know that in a hostile anatomy, in a young patient, definitely we would consider surgery as a first option, but not in this patient with poor bypass. Next slide. So we know this is a type 0 bicuspid. Next slide. So if you look at this, next slide, please. So if you look at this, Jilavi classification, bicommissural non-Raphe type. Next slide. So we know that when you have more calcium with bicuspid valves, outcomes are not very good. Next slide. So we know that there are a lot of challenges in a bicuspid valve. Next slide. With heavy calcium. Our own data published recently has shown good outcome with bicuspid valves in India with both types of self-expanding and balloon expandable valves with the 2-year follow-up. Next slide. So with this patient, coming back to this patient, the ICD was 25.1, the annulus was 23.7. So that's a kind of a flare type. Next, please. So next slide. So sizing was done based on annulus, but here, next slide. So the plan for this patient is a conscious sedation, no transdiaphyseal echo, no urinary catheter, ultrasound guided access. We plan to use a self-expanding accurate neo valve, considering that this patient's annulus is not big, and we thought we'll use the accurate neo valve, considering that young patient, and he has had already some coronary interventions in the past with circumflex stent and all that. So have a good coronary access is always good. And this patient has a bicuspid valve. It's again more challenging to use accurate neo. So it's important, and so in fact, it's mandatory to predilate aggressively, post-dilatation if necessary. We use one femoral axis, the right femoral axis, and one radial axis. So we usually close with the hybrid suture and plug-based device. Next slide. So next, please. So accurate neo, I think you all know, has got its top-down deployment. It's got the stabilizing arches, the upper crown and the lower crown. So we need to deploy the first stage and make sure the valve is well aligned, then deploy the lower part of the valve. And it's a supraannular device, so the gradients will get a much better gradients, lower gradients, so effective orifice areas are higher. So, and with the large open cells, the access to coronaries is good. Next slide. So we have an eye sleeve, and that's quite next slide. So it's again very. The sleeve is just like other sheaths where it goes good expandable sheath. Next, please. So next, let's move to the case now. Can you come live? So any thoughts on the valve selection and any other in the strategy and plan? Let's go.
It's only that the calcium, this valve is not as strong as many of the other valves. So we need to pre-dilate it very well so that.
So should we done an iotogram? Just show the iotogram. Yeah. Show the iotogram. So you can see that it's a bicuspid valve. So type 0. So we don't see only see two sinuses. So you can see the calcium, you can see the graphs. So let us now let's cross the valve.
I think that the point that Ajit's making, the radial strength is one of the concerns, and so it has to be emphasized the pre-dilatation. So they've the accurate prime, which is their next iteration, significantly improves radial strength, and I think will address some of these issues. But until then, I think pre-dilatation and possibly post-dilatation in these type of analysis especially is going to be necessary.
Yeah, absolutely. And more aggressive pre-dilatation, unlike the pre-dilatations what we do for the other valves, we go with a minor diameter. We have to be more aggressive. If you look at this patient has a minimum diameter of 21.6 and a maximum diameter of 25.7. And the mean diameter is 23.7. So normally we go with the 21 balloon or so in regularly, but in this case, we want to be more aggressive, either a 22 or even 23. So we thought we'll use a 23. It's a kind of more aggressive. So let's now cross the valve. There's a AL2 catheter, a straight Teflon wire.
Could they make the fluoro bigger?
Can you make the fluoro bigger, please?
Oh, no.
Just like the previous case, there's a bicuspid type 0. You may have some difficulty because of the eccentric opening of the valve. Sound good?
Yes, I agree. So
can we make the fluoro bigger? We still see it in 4 panels. Can we make just 2 panels with the video and the fluoro?
So I think this catheter, we need to change the note. This catheter is not good. Get me another catheter, please, quickly.
We can also, Dr. Gopal Murugan wanted 5 minutes to do a demonstration. We can go and there's a good point to cut. Let him show his demonstration, and then we'll come back to you.
See, we have crossed the valve.
Oh, you've already crossed. If you've crossed it, we don't want you to delay, so we'll stick
get the get the safari one. Put.
भैया उसको डॉक्टर साहब ने बाइक का ऑन करना.
So Sushil, what are your thoughts on the size of the pre-dilatation balloon?
I mean, I generally would do a 22, but I understand your rationale for a 23, and I don't disagree. But we would normally do a 22 in a scenario like this.
Take. Okay, give me the 23 balloon, please. And pick the chance across and prepare the balloon. Give.
Sushil, are you routinely watching inflation pressures on these pre-dilatations, especially when we're oversizing relative to what I usually do? We've now just gotten into the habit of watching inflation pressures.
Yeah, no, I think it's an interesting point. I do that during the TAVR deployment with balloon expandable pressures. On balloon BAVs, I don't in general because I'm inflating by hand, and I think our ability to get above 2 or 3 atmospheres, unless you're really strong when you're doing with a syringe in a hand, is harder to do.
That's usually 4 atmospheres.
Yeah, at most. I'm weak. Mine is mainly 2, I think. So
I don't know.
Yeah, Arevo.
No.
Yeah. No, I think the issue in.
Sure, that's fine.
In the discussion is the risk of injury, right?
I think it's okay,
When you
Muthu.
do
We'll
this.
put the wire and then
And
it won't turn this side.
And every once in a while,
Safari
especially
wire.
bicuspids, you do a balloon and the leaflet doesn't come back down. You end up with severe AR. And that changes the dynamic and the flow. Everything is rushed, and that's when other mistakes can occur. So I think it's important to have a team and set and ready. And if you balloon and you get AR, then pace rapidly, like at 100 or 100 and maybe a little bit faster to allow the hemodynamics to stabilize. But don't, if you rush and make some sort of error in that scenario, that's even worse.
Come, give me the balloon. So we've always been using extra small here. Most of our LVs are small. So almost 90% of our wire use is Safari extra small. Okay. So you put a pacemaker from the neck. We normally don't need pacing routinely for accurate neo valve, but for pre-dilatation and also for sometimes during the final deployment, we need to push the wire a little bit. Okay, cross. Okay. Connect. Ready? Pacing on. Wait for a second. The balloon has come out a little bit. Okay. Pacing on. Huh? Yeah, go. That's okay. Huh? Can you hear us? Go.
Yes.
Yes, you can.
Go. Yeah, so we stop pacing. See, we were not very happy because the balloon still moved up, but still it opened up. Can you show the recording? Can you take the balloon out, please? Take the balloon out. Take the balloon out. Yeah. Can you show the screen? So ideally, the balloon should fully expand and the balloon should be in the middle of the annulus, so we get a good expansion. So I don't mind, we can do it, though it looked like it opened at the annulus, but maybe we'll do one more dilatation. What do you think?
It seems fine to me. I think it's done enough.
Okay, fine.
It looks good.
Yeah, it looks okay. See, always this bicuspid valve, I'm always really concerned about a very good dilatation in using this accurate neo. Yeah, push the wire.
So you have transthoracic echo in the room though, right?
Yes.
The
Okay,
one thing I will emphasize, there's a lot of different takes on this. In a younger patient with complex anatomy, I don't hesitate to do a sleep with TE because the risks of general anesthesia in a young patient are low. And I feel like TE sometimes helps me optimize the results and prevent complications. So
yeah, I think this is a very valid point, Sushil. I think we should we also consider whenever we need TE. But here we thought at the end, if required, we'll just do a TE and before we take the patient into quickly do a TE. So this is an introducer. So 3 pushes. Can you show me the hand? Can you focus on the hand? So 1, 2, 3. So this is eye sleeve. I'm just taking in we keep it at 6 o'clock position. Can you show that? The splash port at 6 o'clock.
I have to say the eye sleeve is one of the best sheets that's ever been made. In terms of how it passes and everything else.
Okay, can you show up now?
The nice thing about the accurate, I don't know, there's experience.
Same view.
It's a very flexible catheter, so some of these arches it tracks very nicely.
I think it's a very sleek system. It's a nice sheath and a nice catheter delivery.
The delivery will be across
check the pigtail small test.
But it's a very different deployment for people that haven't seen it. It's a top-down deployment.
So if you see this, almost all the 3 transcatheter posts are symmetrical. So I think it's already commercially aligned. So I'm not worried about commercial alignment. So wire is not very good, but that's the only problem here. The anatomy is not keeping the wire facing up. So that will probably try to change the position, take the valve out. Take the valve out here. Valve out. Change, rotate the wire.
I think this is one important crucial thing you are doing because the wire position is very crucial in
I
that.
am not happy with the wire position.
No, absolutely. It's very
Yeah,
important.
So
A nice apical position is very important because the last moment of the accurate neo will be going into the LV. The valve will go into the LV.
So I think I'll take it out and put the wire back in position. Not very happy with this. Yeah, this is RAO position. This is the maximum we can good. Just see if we can rotate the wire a little bit. Take the wire, push and pull the wire a little bit. Now see, come back to the other view. Just seeing if I can push in the wire with this, say, valve in position. Sushil, what are your thoughts now? I am thinking of taking the valve out and repushing the wire, but I'm not sure whether I'll get a better position.
I mean, that's the challenge. I mean, it's not perfect, but it's probably doable. But there's no downside if you want to come out and reposition the wire. I think here you can easily come back out and do all of that.
Yeah, I think I will do that because it's just taking another few steps. But I think it's better we do that.
No, it's absolutely important, GS.
But why push the wire?
Because this valve, the last moment should be forward, and the valve does go in after deployment. So it's very important.
So let's see if we can push the wire now with the wire push.
Maybe we'll step away for about 5 minutes if you want to adjust that. Is that?
Yeah.
Okay. To Chennai, see deployment of the accurate valve. Oh, there it is.
Yeah.
We're back with you.
Yeah. So what happened was the wire, we couldn't take the valve out. The valve could not be taken out. So show that. Show the picture. Show the picture. So we had to deploy the wire position. That's the best thing we could do. But the problem, because of the wire, you see the valve is lifted up. We couldn't get the proper orientation of the marker with the pigtail. So we go next. Look at the position here. So this is what the deployment, a little high. Next. So we removed the nose cone. Show the next, please. So next, this is the one. Okay. So we have a little very high position in the valve, but the valve is still in the annulus. You could see that since a bicuspid valve, it's quite sitting there. So what we were thinking is to see for some time and see. No, actually the hemodynamically is done really well. So we want to see if the valve is stable or not, then decide if we want to put another valve or leave it like that. That's the plan.
So if you put another valve, you'd put a balloon expandable or?
Yes, I think so. I'll put a balloon expandable valve.
Yeah.
Because, balloon expandable valve will just hold this valve fence and then keep it put very well. Whereas to put we can put an accurate neo again. The issue is if I had to put accurate neo, I can definitely do it. But we need to make sure the wire is in good position and make this anatomy again as it's a little distorted. So I have to keep a wire. Maybe I'll try to put one more accurate neo. Maybe, yes, we'll do that.
JS, can you hear me? I think this might hold because
it might hold.
Anchoring is above and it might hold. As you were saying rightly, wait for at least half an hour, whatever it is. But keep a balloon expandable on the backup because that will do a much better job than another accurate.
So that's why the accurate neo, once you take it to the sheath, you cannot bring it back because of the crowns which are that's the main problem. So the wire position, sometimes if you don't get a good position, and then when the wire position changes, have to take the valve in. It's difficult. You can't take the valve out, so you have to accept the position. Try to change the wire position as much as you can, and that's what we did. So we will observe for some time, and then the pressures show the pressures are good. The echo show the echo. Show the echo. What's the gradient? Meek? The mean gradient is 5. Can you show the echo, please? Show in full screen. Show the full screen. Can you show the echo in full screen? Yeah. Can you show the gradient? Yeah. So we have hemodynamically very good. The blood pressures are good and the gradient is good. So what we thought, we will just observe for about say 10 to 20 minutes, and then if everything is stable, we'll probably come out. And this, as you said, this could be bicuspid valve with probably it should hold on. Let me observe for some time. Maybe if we decide to put one more valve, I can show you again.
So
Quickly.
Did you do an aortogram there or?
Yeah, I have done a diagram. Show that we can do one more. Ready? 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 Huh? No, pigtail will take it later because I want to make sure the wire is inside. I don't want pigtail to be taken to the wire. Ready? Picture. Yeah, it's holding on one side. The other side is a little high.
I think this will stay.
Hi. The upper crown is sitting nicely well below the left coronary.
Hi, here's Dr. Ferenc from University Health Center Freiburg Bad Kürzen from Germany. So this patient is quite young. If I understood you right, he is 65 years. So we should have now really optimal result after TAVR procedure. At the moment, there is some risk for dislocation, and this could be really disaster for the patients, because what would you do then? Emergency approach will be probably
I think I will probably put one more valve and fix it, maybe to be more, leave it more. I think that will give us more confidence. So maybe, as you said, maybe it'll stay, but I think we'll decide to put one more valve. Get the pigtail in. We're going to put one more valve. Decided to do that.
I would recommend you to go with the second valve and to achieve perfect result.
Yeah. One more valve.
Hey, this is Mahesh. We have done a few accurate valves, and this is one of the challenges that you have just faced. When the wire position is not right, you could have used the nose cone itself to use as a catheter, pull the coil back and put the coil back in. It'll orient itself in the way you want to.
That's what we did. We tried to do that. We pulling the wire back into the nose cone. But the wire goes back, when we put the wire goes back to the same position and the valve moves back to the same position.
And I also have to agree that I would definitely put a second valve and not rely on this valve for the long term.
Yeah. So I'm going to do that now. So if you want to, we'll do that now. That's the best. Now we'll have to make sure the pigtail is nice position. Give me a regular wire, please. And a regular wire to remove that pigtail.
So if you're putting a second valve, I mean, again, I have very, very limited experience with accurate. Can you put another accurate, or I mean, I would.
Yeah, we can put another accurate
here. You can. Okay.
You can put a sapien accurate. Regular wire.
I mean, we're just talking, whether to put a sapien here or.
Yeah, my suggestion is use some other balloon expandable, either a sapien or a my valve, because I would not suggest a second neo. I have to say I was part of this accurate trial in US, and I know the challenges with this valve.
But in India, I think the cost implication will be big because it's two different companies. And if you're going to put a MyValve in this already accurate, then it doubles the cost.
I know not at this stage, though. This patient is in jeopardy. I understand the cost implications of this, but for this scenario, don't take chances, please.
Yeah, I agree. Okay, then we'll probably do the valve and show it to you a little later, because we might take some time to organize the balloon expandable valve. But accurate neo, we have it right away.
So before we leave, can you maybe just for the audience highlight the challenges with the wire? When you have a second, if you go back to the fluoro image.
Yeah, so it's very, very important not to lose the access to the LV. So the pigtail is very important. I don't want the pigtail to come out for any reason, the wire to come out. It's very difficult to recross an accurate because you have large open cells and you can cross through the struts. I think that's a very important point. And taking in the second valve, we have done it before. So there's an option we can go in and deploy it a little deeper inside, and that's going to anchor it well. So we will look at the option of balloon expandable valve, and we'll come back to you once we've done the procedure.
That sounds like a great option. So what we'll do is we're going to move on to the
Yeah.
next case in JDEVA, and you let us know when you're ready.
Yeah,
So,
sure. Done.
thank you so
Done.
much.
Yeah,
Very nice
we'll come back.
demonstration of technique
you.
and everything.
Thank
Thank you.
Thank you. Thank you.
So maybe we can go to
Just let
Sengottuvelu in
us.
Chennai again.
It comes to the coming.
They have.
We're back now. Can you hear us?
Yeah, Sushil, thank you coming back. Sushil, can you see the fluoroscopy now?
Yes, we can see.
Yeah, if you look at this, after we were observing for almost nearly 10 minutes or so, and you see this upper crown, it's clearly, you can see that now. It's just below the coronary, and you see the narrow sinotubular junction. So if you look at both sides, the upper crown is just below the say STJ. So there is no chance the valve can go up. Next, I'll tell you. Next, you look at this picture, and the valve is, there is no AR. The gradient is very good. And can you show the echo, please? Show echo on a big screen. We looked at the echo. Can you show the echo on big screen, please? Big screen. Okay.
We can see. We can see. Yeah.
Yeah. Can you show the Ganapati? Show the echo, please. Yeah. Show the views what we've taken. We did a TE, and can you show the other view, please? Recorded view. Yeah. Play that. See, if you look at the valve, there is no leak, and you see the valve. If you're looking at the valve, it's quite. You have a very hypertrophied ventricle, and I don't think we can put the valve even lower. Even sometimes put a second valve, the valve can come up, and there is a gross. So because that we were convinced because of this upper crown and this valve, chance of coming out is very low, and we got a good look at this view again. The echo. You can see the echo nicely now. Show the final view.
I mean, on the valve position, at least posteriorly, there looks really good. There's no AR. The hemodynamics are good.
Yeah.
The main concern, I guess, people had was risk of embolization, but now you've observed for about half an hour, and it's been stable. And your point there that the stabilization arches and the crown prevent it from going aortic, and now I think that's a very reasonable sort of consideration. Others on the panel with more experience with accurate, what are their thoughts?
Look at the same view. Come share the same.
I mean, the hemodynamics and the AR and everything look very good. So
okay, I agree. Just let it be. I think it looks pretty good. This one of the challenges with this particular valve, but looks good.
Ganapati. Yes, sir. So I think we are quite happy with this question, and I think we will observe this patient. But I'm sure this patient will do well. And we have very trivial AR, and the gradients of mean gradient is 5. And we did a post dilatation to see if we can push it a little bit. We did a very short post dilatation. The valve really didn't move much, but we were going at fully deployed, fully expanded the balloon, and tried to push it a little bit down. So maybe it moved a little bit down, but we are happy with that.
So it highlights some of the issues of, where does seal occur in a bicuspid here, right? The seal is on the leaflets. It's not, it doesn't need to be at the annulus, and it's about stabilization and seal. You have a good seal, you have good hemodynamics, and the valve appears stable. So I think it's valid and reasonable to continue to follow, and I expect that this patient will do well with this result. So I think
if you look at this, Sushil, if you look at this echo, the lower frame of the valve is almost close to the, you see the hypertrophied ventricle.
So I do think you did highlight an important point. The patient was stable, and to go through the thought process and make the right decision. You put the TE probe down, you did a complete assessment, and I think that highlights some of the things that you have to go through in the thought process, right? Rather than going straight and saying, well, I have to put this, but really assessing what is the result, what are the goals, what will happen with another valve, and where is it going to sit is an important point, because you'll be below the leaflets of the other valve. The LVOT will push it up as well. So it's not trivial to do that. So I think that was a great sort of learning point for all of us here to sit back, think, do the TEE, put the probe down and really assess. So congratulations. I think it's a great illustration, and thank you for sharing that.
Thank you, Sushil. Thank you, Srinivas Kumar and TCT for having us. Thank you very much.
Thank you. So we'll move on. One comment here before we move on.
Maybe one final comment. I think I would suggest to go to cardiac CT again to do scan just from the future information.
I think we do a lot of post CTs because we learn a lot from them, and not only for the acute result, but planning for the future.